Are we good to go? All right, we're going to go ahead and get started. Thank you all so much for joining us today. Today for Grand Rounds and then also for later on this afternoon, we are celebrating Resident Research Day, where we get to showcase all of the projects that our residents have worked under the mentorship of our Department of Medicine faculty on, and everything that they've been working on. So this really is a celebration of scholarship, of intellectual curiosity, and of supporting our resident mission, or of our research mission, as we also support resident education. As is our tradition for Resident Research Day, we always like to ask to have a keynote speaker who is a distinguished physician scientist among the Department of Medicine. Today I'm so excited to have Dr. Alanna Morris come and join us today. Alanna is an assistant professor in the Department of Medicine here, where she's joined us in 2013, and she works as a heart failure and transplant cardiologist. She received her MD degree from Harvard University and completed her residency at Brigham and Women's Hospital. She then continued her training with us here at Emory, finishing 2 fellowships. The first was in cardiovascular medicine and the next in advanced heart failure and transplantation. As a cardiologist, her research interests include the development of independently funded clinical and translational research to investigate race and gender disparities in heart failure progression and clinical outcomes. And she has career development awards from the NHLBI and the Robert Wood Johnson Foundation to examine vascular function and biomarkers of oxidative stress and metabolomics in patients with heart failure. She is also a passionate supporter of medical education and has been a mentor for numerous students and residents who are seeking careers in internal medicine and in cardiology. It is my distinct pleasure to introduce her today, and she'll be talking to us about I'll Never Be the Next Peter Libby, How to Find Your Own Way in Academic Medicine. Thank you, Alanna.
Thank you. So as I was walking in, I saw Tiffany, who we've been working together for the last couple months, and she said, I'm nervous. I said, me too, because this is really a very different talk than what I'm used to giving. And I'm just going to spend the next 20 minutes or so telling you guys my story. So this is just me. And I think if you're thinking at all potentially about a research career, the first step is really just to identify a problem that interests you. And you may not really know what that problem is now. It may come to you, and I think that's kind of my story. So I grew up in Atlanta. I'm one of the few left who can sort of call themselves a native Atlantan, if you will. And I left Atlanta and I went to college in New Orleans. And I was really excited about this transition. Xavier was known for getting people into medical school, and I thought that as 2 cities that New Orleans and Atlanta would be fairly similar size. They were both in the southeast. I wouldn't be far from my family. But when I got there, I experienced something that I wasn't used to. So I grew up in Buckhead. This is absolutely not my house. But, I mean, you guys live in Atlanta, so you know that Buckhead tends to be an area that's very glitzy. It's very glamorous. This is the shops of Buckhead. So I was kind of always used to being around things being very new, things being very glitzy, and not necessarily seeing the spectrum of how people live. And like many historically black universities, Xavier is in a neighborhood of New Orleans called Gertown. So most of you, when you go to New Orleans, you probably don't go to Gertown. You go to over by Tulane, you go to the Garden District. But this is where Xavier was. And this was kind of the first time that I had lived in a neighborhood that had seen a lot of despair. And I went to school in this. I walked around this neighborhood, et cetera, et cetera. I interacted with the residents. But part of a lot of what we did as students at Xavier was to try to invest back into this community. So I did a lot of community service as a student, and I really got to hear people's stories, and I really got to see how important where you come from means. All of us don't start with the same amount of investment, and the journey that people have to travel really varies depending upon where you start. So as opposed to my start, I guess, coming from a place like this, I interacted with people who really start with very little and had to really work themselves up if they were going to achieve. And that really, I think, made a strong impact on me during my formative years. So I eventually, obviously, left New Orleans, and I went to Boston for medical school. Again, with these sort of thoughts, none of this had crystallized at that time. But I went to Boston, and this was going to be a very, very different environment than what I was used to in Atlanta and Xavier. And the second step at that time was really to use mentors to find out how research can help you address the problem that interests you. And again, at this time, I don't think I knew what problem interested me. I just knew that I wanted to do something to change the disparities that I had seen in a place like New Orleans and in a place like Gertown. So when I got to Harvard, I was part of this pathway called the New Pathway, so we did sort of our traditional classes in the morning from 8 to 12, and then you could take electives in the afternoon. This was sort of revolutionary medical curriculum at that time. And one of the electives that I chose to take was taught by two gentlemen named Paul Farmer and Jim Young Kim. And for those of you who aren't familiar with these gentlemen, they founded an organization called Partners in Health. This was sort of the Boston equivalent of Doctors Without Borders, if you will. And I'm just going to read you a statement from the Partners in Health website. Our mission is to provide a preferential option for the poor in healthcare. Partners in Health strives to achieve two overarching goals: to bring the benefits of modern medical science to those most in need of them, and to serve as an antidote to despair. We draw on the resources of the world's leading medical and academic institutions and on the lived experience of the world's poorest and sickest communities. At its root, our mission is both medical and moral. It is based on solidarity rather than charity alone. And I highlighted that our mission is both medical and moral. That really resonated with me. This was probably one of the first times I was a brand new medical student, but to hear these really exciting, dynamic people who would come into our lectures talk about our moral obligation as healthcare providers to change the inequities that existed in our society. That was the first time I had had conversations like that, but I was like, yeah, I get it, especially sort of coming from what I came from in New Orleans. And I was really sort of excited about the prospect of this. At that time, most of the people who I knew who were working with Partners in Health were working outside of the U.S. It was more of a global mission. So many of my friends working with this organization were going to Haiti or Rwanda, places that were so poor and had such awful healthcare systems because their countries were so poor that they were really just helping to establish a basic health infrastructure in those countries. But for me, this kind of resonated, and I said, well, there are places in the U.S. that kind of experience those levels of despair too. And can I sort of take this type of thought and this type of mission and bring that back to what I want to do? So as a med student, I was sort of having these conversations with people, and someone said to me, you should meet Michelle. You should meet Michelle Albert. She was this very dynamic cardiologist on the faculty at Brigham and Women's. And I went and sat down with Michelle, but before I went and talked to her, I just did a quick PubMed search and I looked at what kind of things she was doing. I had done some research as a college student, mostly during the summers, but not anything sort of truly substantive because I never took any time off sort of during my trajectory. So when I looked up what Michelle was doing, at that time, Paul Ridker was her mentor. And for those of you who don't know Paul Ridker is sort of one of these big luminaries in cardiology who's built his career around the link between inflammation and atherosclerosis. And so Michelle was doing stuff with Paul, but she was looking at things that I think were a little bit more akin to things that I was interested in. So she was publishing papers like Inflammatory Biomarkers in African Americans, a potential link to accelerated atherosclerosis, or CRP levels among women of various ethnic groups living in the U.S., or even things like the impact of traditional and novel risk factors on the relationship between socioeconomic status and incident cardiovascular events. So rather than thinking about like G-coupled receptors and tyrosine kinase pathways, Michelle was sort of looking at the bigger picture and trying to look at not only the impact of sex and race, but also social determinants of health. And that really excited me. So I started working with Michelle as an intern. We had some research time during our second year, sort of similar to what you guys have. And I was fortunate enough to be on this paper. Now, I'll be honest with you guys. I had no idea what Michelle was talking about half the time. This paper was on candidate genetic variants that sort of influence levels of these 4 inflammatory biomarkers. I had absolutely no background in genetics. I had absolutely no background in statistics. So I would go and I would sit down with Michelle, usually after some long 30-hour post-call shift, or I would do stuff when I was on call in the middle of the night. And she would sit and she would program stuff in SAS, and I didn't know what SAS was. She would pass me these outputs and she would just say, like, go make these tables, make it pretty. And I'd make the tables and I'd send them to her, and then she'd tear them up and send them back to me and have me redo them. And that work earned me a name on this paper. But in terms of our research sort of really making genuine sense to me, I can't say that at that time it totally did. And I think that's okay, because I'm sure many of you may be having that experience right now with the mentors that you work with. And I think the point is just to get your feet wet, particularly if maybe this is the first time that you've done a research project with a mentor. At the same time, I was going through residency, so I was doing my clinical training, and I realized that the stuff that I like to do all gravitated around cardiology. So this is Peter Libby, again, very similar to Paul Ridker, really built his career around looking at the link between inflammation and atherosclerosis. He was one of my first attendings on cardiology when I rotated, and I was super nervous to rotate with him. But he and I kind of hit it off, and we really liked each other. I also rotated with people who were just really fun, people like Lynn Warner Stevenson, Eldrin Lewis, Ken Boffman, who's now deceased, who really sort of made me feel like heart failure was the thing that I wanted to do. And so I knew this, and I pretty sort of focused on cardiology fairly early. And then midway through my second year, I had to sit down with my program director, who, much like Karen, is sort of one of the nicest people that you'll ever meet on the face of the earth. I think you have to be to direct residents. And so it was midway through my second year, and Joel said, okay, well, Alanna, what are your plans? And I was really tired. At that point, I was midway through residency. I hadn't taken any time off. I had been working like a dog. And I said, Joel, I'm tired. I know I want to do cardiology, but at this point, I just feel really tired. I almost feel like I need a break. And he said, well, that's understandable, because being a resident is definitely not one of the easiest things that you'll do in your career, but we still, need to think about where your career is going to go after this. And I literally said this to him. I said, I don't know, Joel. I feel like I just need some time off. I just don't think I'm going to be the next Peter Libby. So I admired what I saw people doing around me. I admired the idea of having this influential career with over 400 publications and being the chief of cardiology at a major academic institution. But I just didn't know if that was for me. And of course, a lot of the people that were in those positions didn't necessarily look like me. So it was difficult for me to visualize myself being in that position. So Joel kind of laughed when I said that. And he was like, that's fine. You definitely don't have to be the next Peter Libby, but we should probably figure out who you are going to be. And I just kind of stared at him like this. Of course, we didn't have emojis at that time, but I'm sure that's the face that I would have made if we had. So step 3 for me was to take a break. If you want to, or if you need one, to figure out what you want to do. So my journey continued, Atlanta to Xavier to Harvard. I had been away from my family at this point for at least 11 years. My father actually passed away right as I was graduating from college, and so I spent 7 years in Boston. It was cold. It was a lot of hard work, and I was really desperate to come home. I wanted to be near my mom and my sisters and my nieces and nephews, so I knew that Emory was a kind of a place that was really important for me to come back to. And the cardiology division here was incredibly dynamic, full of people that were doing really exciting things. So I came here and I interviewed for the clinical investigator pathway. And I remember hearing about this path, and I said, okay, wait, you're telling me that I have 2 years of protected time to just do research? I don't have to take call. I only have to see patients in clinic. Okay, awesome. This sounds like a really good thing to me. And I was really excited about the idea of having time off in an academic setting and really being able to focus in on the possibility of doing research with a mentor and having someone guide my steps. So I got introduced to Dr. Kayumi during the time that I was interviewing. And when I was researching him before my interview, I saw that he was working on this study called the Meta Health Study, which stood for Morehouse and Emory Team Up to Eliminate Health Disparities. And so I was like, awesome, this is exactly what I want to do. It wasn't heart failure related. Remember, I sort of showed you pictures of all these heart failure people at the Brigham who I admired. But I knew I really wanted probably to study health disparities if I was going to do research in anything. So it was cool. So Dr. Kayumi introduced me to all these different concepts that I had not been introduced to when I was at the Brigham, things like oxidative stress. We did some work on inflammatory biomarkers, but we looked at sort of the relationship between these biomarkers and how that impacted vascular function. But also as part of this study, particularly because of the collaboration with Morehouse, we looked at things like depression and racism and social determinants of health and how those things impacted all these inflammatory biomarkers, these measurements of vascular function. And I just thought the stuff that we were doing was super duper cool. So the second step while I was with him was just to build a research portfolio, start writing abstracts, start writing manuscripts, and just kind of build what it is you think your career might go into. I also formed research networks. I work with people like Dr. Vaccarino, who was probably a little more interested in things like depression and sex differences at that time than maybe Dr. Kayumi was. I got to meet Gary Gibbons, who was sort of the director of cardiovascular research at Morehouse at that time, who's now the director of the NHLBI, or people like Dean Jones, who's now a co-mentor on my K23. And again, this work just really resonated with me. It was a really incredible time. I had to learn statistics. I had to learn how to write scientific papers. It was a sort of learning how to speak a new language, but I loved it. Every time I got an abstract accepted to a meeting, I loved it. Every time I got a paper in print, it really excited me. And I think part of the reason maybe this experience was different than what I had done in residency was because I had time. I had time to learn. I had time to read. I had time to think of my own ideas, and I had time to let it all digest. So I had a lot of success when I was a fellow. I published a bunch of papers. My work really looked very much like what Dr. Kayumi was doing, but that was fine because it really interested in me. So I did a lot of stuff with oxidative stress, different measurements of vascular function. I did some other stuff that I think was more interesting to me by working with people like Dr. Vaccarino, looking at the relationship between depression and inflammatory biomarkers. And things just really sort of got off to a good start. And then I had to go back to the wards to do my fellowship training, right? I still needed to become a doctor. And I can remember one of the first times that I was on Grady Consults as a general cardiology fellow, and I got called about this young man in the ER with ST elevations on his EKG. And the ER resident was explaining this to me. She said he totally feels fine. His EKG looks terrible, but he's not complaining of anything other than some fatigue. And oh, by the way, his MAP is like 180. And I was like, you're completely retarded. Like, you just don't know how to take a blood pressure. So I run down to the ER, and I take the blood pressure myself with a manual cuff like 5 times. And she was right. I mean, the blood pressure was really this high. And I put this picture up because this is exactly what this guy looked like. He was a young African-American male, and his only risk factor for hypertension was the fact that he smoked. And this was around the time that we were going into the recession, and he'd been working and then had lost his job, so he'd run out of insurance, and he had run out of his medicines about 3 months before this and didn't have any medicine, and sort of showed up in the ER that day at Grady because he just didn't feel good. I had never seen a blood pressure like this when I was at the Brigham. In 7 years in Boston, no one presented with blood pressures like this. And if they did, they would have immediately been transported to the ICU with like a nitride drip, a fundoscopic exam, and like the whole 9. But you guys see this all the time at Grady. To me, I was like freaking out running around the ER, and I could not understand how this guy was just talking to me. And so this was really interesting to me because it kind of put all of the stuff I had been doing with Dr. Kayumi into context, right? Thinking about the role of oxidative stress and social determinants of health, maybe the impact of racism, maybe the impact of social determinants of health, how patients lose their insurance, can't afford their meds, and then show up in an ER asking for our help with this pathology that's just so severe. And then I did my heart failure training, and it sort of amplified all these things for me. As you guys know, because you take care of these patients with us on service, we see an enormous amount of heart failure, but particularly an enormous amount of heart failure amongst young African Americans. I started reading the statistics that mirrored what I saw every day in practice, that African Americans have about a 3-fold increased risk for developing dilated cardiomyopathy, even for the same set of clinical confounders, even when you look past access to care and socioeconomic variables, and have about a 2-fold higher risk of dying from dilated cardiomyopathy. And as a heart failure physician, for the first time, I had to think about social determinants in a different way than I ever had to before. When I was a resident and a fellow, I never asked patients what kind of insurance they had. I didn't care. I just took care of them. But when I'm working someone for a transplant or a VAD, their access to care 100% impacts the care that I can provide for them. And we often have to turn patients away because they don't have access to care. And that really kind of broke my heart, seeing all these young people who often had Medicaid or who had nothing because they just got sick very quickly, and I had nothing to offer them, and I just had to send them home with palliative care to die. And that's probably the hardest part of what I do. And so sort of training for me really put, I think, the research into clinical perspective. I had done this work with Dr. Kayumi, sort of looking at the underlying physiology, and then I saw it every day, day in, day out, in the patients that I was taking care of. And it made me realize that this problem is super duper important, and I wanted to be the one to try to fix this. So I kept working with Dr. Kayumi. I gained a new mentor in Dr. Butler, who's no longer here. And then I would talk to Dr. Taylor. He knew I had sort of had a certain amount of success as a fellow. And he said, okay, I think, it may be reasonable to think about you staying on faculty, but I need you to get a K-23. And I said, I don't know what that is, but I'll do it. So I started thinking about writing a K-23. And, that's sort of step 4. I can't remember if I'm on step 3 or step 4. So build a portfolio that defines who you are and what your scientific contribution will be. So again, as I joined faculty, I started to sort of do my own thing. I was still working with Dr. Kiyumi, but I was moving more into the field of heart failure. And I started looking at some of the biologic factors that maybe influence racial differences in heart failure outcomes, including the role of inflammation, the role of the immune system in terms of how our patients present and why African Americans are at such a high risk for rejection even after they've had a heart transplant. I also ventured out again and started looking at sex differences because there's really important sex differences where women have worse outcomes after LVAD or are less likely to get an LVAD in the first place. So I really started to sort of define and look at things that were important to me. I definitely had a few failures along the way, and I put failures on quotes. If any of you are going to do this work, you have to have thick skin. So like most people, I ended up figuring out what a K-23 was. I submitted one with the help of Janet Gross, who's helped a lot of us write these grants. And of course, it got scored but didn't get funded the first time. So I had to go back and redo this. And for those of you who've ever written a grant, you know it's an incredible amount of work. You put a ton of time into this, and the reviewers really don't care. They're just like, this sucks. Do that over. This aim is total trash. Like, they do not necessarily take your feelings into account when they're writing their comments, but you just got to like breathe deep, drink a glass of wine, and then go back and keep at it. And so that's what I did. And so I was actually rewriting my K-23 my second year as an attending. And oh, by the way, I had to study for heart failure boards at that time too. And oh, by the way, somebody told me that if you really want your K-23 to get funded, you need to do a master's program and get a master's of science in clinical research, as though being a heart failure cardiologist wasn't enough training. So I was doing all this stuff at the same time. And it literally felt insane. But fortunately, it all worked out, right? So we're all capable of doing more than we ever think that we can. And so not only did I get the K-23, I also got this really neat career development award from the Robert Wood Johnson Foundation, where I work with people who tend to think like me, who think about the role of disparities and the role of social determinants of health and how that impacts health outcomes. I passed my boards, thank goodness, and I finished my master's. I didn't fail out of the program, so it all worked out. And then as I kept sort of going in my career, I added new areas of expertise. Again, I started to focus in on the role of social determinants, because you really can't talk about health disparities without talking about social determinants of health. So I started looking at things like food deserts and how that relates to heart failure hospitalizations, or the role of insurance for our patients being eligible for advanced heart failure therapies, because I saw this every day in terms of the patients that I took care of, but there really was no published literature looking at the impact of things like that. And forming new collaborations with people like Neil Dickert, who many of you know, who looks at the role of shared decision-making and how that may impact our ability to prescribe very expensive new medicines to patients who maybe can't afford them. So again, this was all exciting to me, and I think if I kind of define myself now, it probably looks something like this. When you're a junior faculty, people always tell you, be focused, be focused, be focused. And that can be really hard to do, especially for someone like me that's looking at a field that is inherently very unfocused. Because if you think about disparities, again, the biologic determinants may start with things like oxidative stress, nitric oxide, bioavailability, or even genetics. But then you add on top of that traditional risk factors, and you add on top of that a lot of non-traditional risk factors that we're really terrible at studying in cardiology, like access to care, food deserts, neighborhood, all this stuff. And all of these different pathways actually impact our patients' predisposition towards developing heart failure. But this gives me a lot of work to do, and hopefully will keep me busy for a very, very long time to come. So I think the point is, keep working hard, and your hard work will pay off. If I think about how I spend my time right now, it's crazy, right? I work with you guys on the wards. I work with cardiology fellows. Somehow somebody thought that I was a reasonable person to put on this picture. Thank you very much. But I love this. But sometimes when I'm doing this, I get overwhelmed by the amount of clinical problems that I see. And so it's nice to be able to step away from patient care sometimes and go back to my lab and see a new problem and write a new grant or write a new paper to sort of address that problem in a way that then gets published, such that it leaves a legacy that hopefully I can go back to, that other people can go back to, and that brings an awareness to a problem that I think is really important. I would say the biggest part of how I spend my time is actually service. So I spend a lot of time doing things for the School of Medicine, mentoring medical students for discovery, part of the Medical Student Research Committee. I spend a lot of time on committees for the American Heart Association, the ACC, the International Society of Heart and Lung Transplantation, the Heart Failure Society of America. But I love this because by interacting not only sort of on a local level, but also on a national and international level with these various organizations, I get to meet really cool people, people who are very influential in the field, people who influenced me, but I also get to kind of add my tidbits and bring my voice, which I think is really nice and really humbling. I also have 2 kids just to add some fun to the mix. And on a good day, right, for those of you who have kids, your kids sort of look like this. They're all pretty, but in reality, most of the time it looks like this, where things are just nuts all the time. But that's okay. I also spend a fair amount of time mentoring. Some of these faces are familiar to you guys. Chris Chen worked with me on a project last year and got a couple publications out of it. Mike Yen was with me a few years ago, and we're finishing a paper that he submitted. Sarah Hutchison was one of my first discovery students. She was absolutely awesome. And Tiffany, who's working with me now on the role of psychosocial determinants in our transplant patients. So, when you're thinking about a career in research, this is not for everybody. And I would say, as I was making this list, if you ask, is research for you? Some of the pros, I think you're sort of like a small business owner. You have to manage people. I have a research coordinator, a fellow. I've got people that I work with. And what you get out of it really depends on the amount of time that you put into it. But it also means that I have an incredible amount of flexibility with my time, especially now that I have young people that I have to take care of. My 2 girls, it's really nice to be able to get up early and do my papers and finish my grants, but then go to daycare for a party at 3:30. I might not be able to do that if I were a cardiologist in private practice because I'd be working for someone else. I also feel like it's really exciting to be able to make a dent in solving real clinical problems like the ones that I was describing to you. I'm constantly reading and writing and hopefully learning. I think it's exciting to have these moments on stage where you're at an international meeting or a national meeting talking to a group of your peers and telling them about a particular area that's really important to you. Again, you get to have these really phenomenal interactions with other really important people in your field. And at a certain point, maybe you become a really important person in your field. And I think that this offers greater flexibility for the next step. I tell myself all the time, because Michelle told me this, I have to have like a 5-year plan and sort of figure out where my life is and whether or not things are going the way that I want them to every 5 years. And so far, things are going pretty well. But if I decided that academics wasn't the place for me, I feel like I have enough sort of breadth of opportunities and things that I can hopefully do whatever I want to do after this. I think some of the cons may be that, again, you're like a small business owner. So again, what you get out of this is what you put into it. It's not like I finish my last note and I'm done for the day. As a researcher, sometimes it feels like your work is never done. There's always a paper. There's always a grant. There's always review for someone else. There's always some committee work that has to be done. And in reality, you really only make a dent in solving these real problems. I don't think I'm going to solve health disparities in heart failure, but maybe I'm going to bring more attention to it. Maybe I'm going to get people to think about it more. You probably won't drive a Ferrari. I'm not sure if that's one of your goals. It wasn't really mine. You might drive a Ferrari if you patent something really awesome, but I don't have any patents, so that's probably not going to happen for me. Again, one of the cons is that you are constantly reading and writing, so your work is never done. You're constantly thinking of what's the next step, what's the next innovation for me, and that can make work-life balance somewhat challenging. And then finally, you have to have thick skin because you're going to get a lot of no's, you're going to get a lot of rejections, you're going to get a lot of this is not high priority enough for my journal, and you just have to keep going. You just have to look for the next journal. You just have to look for the next publication that may be interested in your work. So I think in summary, do you have a scientific question that stimulates you? It could be mouse models, it could be drug development, it could be social determinants of health, it could be community engagement, it could be health services research. It can really be anything. But if there's something I think that drives you and that you think requires more attention and needs more attention and needs more innovation, this may be an opportunity for you to think about steering your career towards research. So I acknowledge people who've mentored me here, in addition to other places, my different funding sources, and I thank you guys for the opportunity to talk to you.
All right. Thank you so much, Dr. Morris, for those wise words, and also for being open enough to share your experiences. I know that so many of our residents feel like they are at that confluence that you described of being tired and in a little bit over their head, but also really passionate and enthusiastic and curious about something that they want to investigate further. So I think that your career pathway has a lot in terms of what we can use to inspire us to move forward. So now I'm really pleased to present to you our 3 oral abstracts. We had a banner year in terms of resident participation in research, mentored by Department of Medicine faculty this year. So we had 52 original research abstracts as well as 48 clinical vignettes that were submitted. And the 3 oral presentations that you're about to hear were the oral abstract winners based on a blinded a review of a review committee with the chief residents and some of our Department of Medicine faculty. So in the interest of time, I'm going to ask that you all hold your questions until all three presenters have had their opportunity to present their abstracts. And we are going to start with Hima Veeramachaneni. So if you want to come up, and we'll bring your abstract up, or we'll bring your slides up. She was mentored by Dr. Leslie Miller, and she's going to be presenting her work on differences in inpatient and outpatient HCV prevalence and linkage to care rates in a safety net hospital hepatitis C screening program. Okay, thanks, Hima.
So as you can see, I'm Hima, and essentially this long title means that I'm going to be talking about our hepatitis C screening program at Grady, and I'm going to be looking, we looked at the prevalence rates of hepatitis C as well as the linkage to care rates, and we compared those in both in the inpatient and outpatient setting. So I'd like to thank Dr. Miller, who is my mentor, and Ms. Park, who helped a lot with the data gathering for this project and are my co-authors on this. So these are the disclosures. As we all are familiar with, hepatitis C is very common. In the U.S., about 1% of people are infected with hepatitis C, and in the birth cohort, which is the patients that were born during the years of 1945 to 1965, that risk is about 3% of people that are infected. However, only about 50% of people actually know that they have that infection. So that creates great implications when it comes to transmission and sequela and down the line complications. So that's why it's so important to have a screening program. And furthermore, it's important because this can be very deadly. The CDC reports that the deaths related to hepatitis C are more common than HIV and 59 other common infectious disease complications. So it's very deadly with regards to hepatitis C causing cirrhosis and hepatocellular carcinoma. And so screening for this and detecting it early will definitely help improve some of these numbers when it comes to comorbidities related to it. And it's curable. So once the patients are actually identified, as we all know, there's a lot of novel hepatitis C treatments. There's a greater than 95% SVR rate. So if we can find these people, identify them early and get them cured, it actually creates a great implementation of the screening program. So the CDC has taken this on, and they have a screening initiative, specifically targeting those in the 1945 to 1965 birth cohort. There's TV ad campaigns. There's a big push in most hospitals for this screening. So it's become a very important priority to identify these people. So bringing it home to Grady. Grady has implemented their own outpatient screening program. There was a screening program in 2012, but this research particularly focuses on a screening program implemented in 2015 that focused on an EMR-based screening initiative to push providers or encourage providers to screen patients that fell within the birth cohort. And we're going to talk about that a little bit more. The inpatient part of this screening program did not start until 2017. So there will be a comparison between the two, but there were different times where they were initiated. And most of the data that exists on this is actually in the outpatient setting, and it's been very successful in the outpatient setting at identifying those that are at risk that have hepatitis C and linking them to treatment. So this comparison is pretty new between the outpatient versus inpatient screening. So what are our big questions? The main things are, is there a variation in the rate of prevalence of hepatitis C in the inpatient versus outpatient settings? And of those people that are identified in both settings, is there a difference in the linkage to care? So to start off, to orient everybody, we're going to be talking about the patient starting at the left. So hepatitis C, they get a screening test. And if they're antibody positive, then they get an RNA test. And if that's positive, that indicates an active infection. And then they would be linked to care. We'll talk about exactly what linkage to care means in a little bit, but that's essentially what we're looking at, these different steps and how patients go along this cascade. So our methods, we included data from March 2017 to March 2018 in both settings, and we looked at the care cascade. So the way this was implemented, there was a best practice advisory. For anybody who's at clinic at Grady knows that if somebody is born between 1945 and 1965, they actually have a best practice advisory that pops up in their clinic patients to encourage them to screen for the test. And if the patient agrees, then it's simple as clicking this accept button to open the SmartSat and get them the test ordered. On the inpatient setting, which was implemented in 2017, it's actually an opt-out system. So for anybody that does a general admission order set, the hepatitis C antibody screening test is on there and it's already pre-clicked. If the patient is inappropriate for testing or if they decline testing, then you have to click out of that. So it's something that they've also implemented for HIV based on this program, but we're going to focus on the hepatitis C portion of this. And so then linkage to care. So we've got these people, we've identified who they are that are infected, and now we're going to figure out how to get them to clinic so that they can actually get the treatment that they need and the education that they need. So in the outpatient setting, this can work in multiple different ways. The requirement for most people is that they come to an education appointment at the liver clinic and figure out what hepatitis C, what does this diagnosis mean, what complications can occur, and why should I get treated is kind of the liver education component of it. The other ways to get linked to care or be counted as linked to care is if they directly went to a liver clinic appointment or had an infectious disease appointment where they discuss hepatitis C and discuss treatment. And finally, the last way is if they had a primary care appointment where the discussion was had about hepatitis C and were referred for treatment. On the inpatient setting, it includes all of those options, but also an actual bedside navigator that comes to the patients in the hospital and talks to them about hepatitis C and educates them regarding the importance of following up the infection and the treatment options that are available in the outpatient setting. So it's a lot more robust, given that there's somebody that's one-on-one talking to the patients regarding their diagnosis. And again, as I said, all the above linking strategies also apply. So looking at our results, the demographics of our patients, there were about 10,800 people that were screened during this period. Of those, about 7,000 were in the inpatient setting. As you can see, the percent in the birth cohort in the outpatient was a little bit higher at 73%, but the Black male demographic is pretty consistent with the demographic of patients we see at Grady. In the inpatient setting, it was a little higher to be male, but generally similar characteristics in both groups. And here we have the results. So if you look at the first column, first row, you're looking at the 10,800 patients we just talked about. Below that in the next row, you will see the number of patients that were positive for the antibody test. So of the 10,765, 1,025 had the antibody positive test. Of those, about 67% got an RNA test performed, and of those, 68% had a positive RNA test indicating an active infection. And then the last row shows the number of people total that got linked to care. So one of those strategies that we just talked about. So about 70% total. Now I'm going to bring your attention to the red parts because that's actually what's most significant. In the inpatient setting, you can see the prevalence was about 14% for antibody positivity, but the linkage to care was only 54%. And in the outpatient setting, the antibody positivity was 7%, and the linkage to care of the active infections was 91%. And overall, if you look at the prevalence, as I had mentioned earlier, only about 3% of the baby boomer population actually has infection in the U.S. as prevalent, and only 1% of the total U.S. population has hepatitis C infection. So all of these numbers are significantly higher than what the U.S. general prevalence rates are. So I will bring your attention to this part because we'll talk about it a little bit more, but only about 60% of people or 70% of people that had a positive antibody test actually got an RNA test performed, and we'll discuss this a little further. So as I had mentioned, why are the prevalence rates so different? Why is the inpatient setting so much higher? And there's some things that we don't have the data for, but the main consideration that we had is the potential secondary risk factors. So not just birth cohort, as was indicated in the outpatient setting, but also IV drug use, abnormal liver enzymes, co-infection with HIV, which is something that we see a lot at Grady, and other comorbidities that we may not know be playing a role into both of these. And so often the patients in inpatient are a lot sicker and might have more further comorbidities. So we don't know exactly what comorbidities they have, but that's what we assume is the reasons for the difference in prevalence. Now, the linkage to care rates is probably a little bit more complicated and multifold. There is a robust linkage strategy, so you would think, well, if somebody's coming to bedside to talk to the patients and actually get them to come to clinic, that they would actually be able to do that. But the issue is that a lot of these patients were in the ICU or passed away before they could make it out of the hospitalization or are co-infected with other things and often don't fall up for those either. And the patients that do have an outpatient screening test that's positive have already been in the outpatient setting at Grady. They probably consider Grady as their medical home and have been navigating the clinic system in the outpatient setting for multiple years. And so it's a lot easier for them to attend a liver clinic appointment that's been made when they know how to attend an appointment at Grady in the outpatient setting. So those things can definitely be playing a role in this difference to linkage to care. So the limitations, as I had mentioned earlier, only about 60% of the people that had positive antibody tests had had an RNA test performed. So why is that? Well, before July of 2018, there were no reflex testing. So you would have to get a second blood sample from the patient in order to get an RNA test and see if they had an active infection. And a lot of times that would be on the behest of the provider to order that, or the patient to come back to clinic to be able to get that, or come back to the lab, or still be hospitalized to be able to get that RNA test. So that was a big barrier. And because of this, the reflex testing was started in July 2018, and now greater than 99% of people get their RNA test reflex after their antibodies positive. So we know if they have an active infection from just that one blood sample. And as I mentioned earlier, the comorbidities are a huge deal. So we don't know what other medical problems that these patients had, how sick they were, and how that plays a role into linkage to care and prevalence. So where this project is going, we are expanding screening to other settings, to the emergency department and to the obstetrics clinics. It's already been expanded to the ambulatory specialty clinics and the walk-in clinics. So we've definitely reached more of a target audience. But we're screening all these people, but we need to come and make sure that they get treatment, because ultimately that's what's going to improve the outcomes. And so we're working on probably a potential qualitative study in the future to discuss with our patients what their limitations are, what their barriers are to be able to get to the appointments, to figure out why there's such a drop-off rate. There's already a robust navigation system where patients get called frequently to make sure they make their follow-up appointments, and the navigators at the liver clinic are pretty good at that. But identifying those barriers can further help improve those linkage to care rates. These are my references and my acknowledgments. Thank you.
All right. Next up, we have Tiffany Dong, and she's going to be talking to us about excessive daytime sleepiness and its association with higher mortality in patients with cardiovascular disease. And she was mentored by Dr. Arshad Kiyumi.
So before I begin, I'd like to thank Emory for allowing us to present this research today. And this is a topic very near and dear to our hearts. If you're a med student, especially if you're a resident, and definitely if you're an attending, excessive daytime sleepiness is associated with a higher mortality rate in patients with cardiovascular risks. So there are no financial disclosures associated with this talk. A little bit about background. So excessive daytime sleepiness is defined as the inability to maintain wakefulness during major waking periods occurring almost daily for about a month. In population-based studies, we know that excessive daytime sleepiness is associated with worse cardiovascular outcomes. However, in a patient population who has CAD, we need a clear understanding of the role of excessive daytime sleepiness. So the aim of our study was to examine this role. In patients with CAD, we looked if daytime sleepiness was associated with an adverse outcome in a dose-dependent manner in this in the CAD population, and we used the Epworth scale, which is on the next slide. So this is a scale you can administer to your patients in clinic. It provides 8 scenarios where the patients rank themselves 0 to 3, 0 meaning they would not doze off during one of these events, and 3 being a high chance that they would doze off. When we start to think about daytime sleepiness, our scores are either 11 or higher. So for our study, we did a prospective cohort of 1,769 patients from the Emory Cardiovascular Biobank. They were taken from 3 different Emory sites. We excluded all transplant patients. We collected Epworth scores as well as demographic information, including baseline characteristics, cardiovascular risk factors, and comorbidities. Then we followed these subjects for a median of 1.8 years for both the primary endpoints of all-cause and cardiovascular mortality. And then our analysis, so we did an ordinal logistic regression to identify baseline characteristics that were independently associated with higher Epworth categories. And we also did a survival analysis with Kaplan-Meier curves for both all-cause mortality and cardiovascular mortality. After that, we performed a Cox proportional hazard model with multivariate adjustments. And I'll list the variables below those figures. So this was our distribution of Epworth scores. And as you can see, we divided our population into quartiles. So like I mentioned, the number that we start to think about excessive daytime sleepiness is about 11 or higher. So we divided our normal group into two, low normal being a score from 0 to 5, and that had most of our population at 44%. High normal with 34%, and that was greater than 5 to 10. Mild to moderate being defined as greater than 10 to 15. And severe with the least amount of people in this population being defined as greater than 15. So these are our baseline characteristics. As you can see, we did age as well as comorbidities and cardiovascular risk factors. And then we did this ordinal logistic regression. So we found that age per decade, BMI, diabetes, and a history of AFib were all independently associated with higher Epworth scores, and this was in a multivariate analysis. So then we move on to our survival analysis. So in our Kaplan-Meier curves, I'm going to start with all-cause death. And you can see the x-axis is the time to all-cause death, and the y-axis is cumulative survival rate. In the navy blue line, you can see that this corresponds to the low normal group, and they had the best survival rates. In contrast, you can kind of see the severe lighter blue line had the worst survival group. You can see a clear definition if you look at the Kaplan-Meier curves for cardiovascular death. So again, with the low normal group having the best survival rates and the severe daytime sleepiness group having the worst survival rates. This is our Cox regression analysis. So we use the low normal group as our reference group, and then we compared that to high normal, mild to moderate, and severe, adjusting for the variables as listed below. And then this is the graphical representation of that. So the x-axis we broken down into groups, and the y-axis is our hazard ratios. As you can see, even the high normal group has a higher association with mortality risk compared to the low normal. And this association, the hazard ratios increase. So 1.45 to 1.6 as you go from high to mild to moderate daytime sleepiness, and then with severe having the worst hazard ratio of about 1.95. Again, we see similar findings. We have similar findings in our cardiovascular mortality as well, with worsening hazard ratios as the severity of the Epworth score goes up, including even the high normal group patients that we might not necessarily think of having daytime sleepiness. So, of course, our study is not without limitations. We are a single-center study and liable to all limitations due to that. We also don't know the etiology of daytime sleepiness in our population. Most commonly, we think of obstructive sleep apnea for patients. However, there are different other causes of daytime sleepiness, such as narcolepsy, sedatives, central sleep apnea. We also don't know if they were undergoing treatment at the time during our study for their daytime sleepiness, so including CPAP use. We don't have the numbers on that. However, I think our study, we can conclude that we showed a higher mortality risk in patients with CAD in a dose-dependent fashion, particularly in the high normal group, which is a little surprising, considering that maybe this is a population we forget about. And then, in addition, our study is the first to demonstrate differential levels of mortality risk over the spectrum of the Epworth scale. And then we pivot to further studies. So we do need to elucidate the mechanism by how daytime sleepiness affects cardiovascular outcomes and mortality rates, and whether interventions that reduce daytime sleepiness actually lead to better outcomes. And with that, I'd like to thank my research mentors, Dr. Kayumi, Dr. John Juan, and the Emory Clinical Cardiovascular Research Institute. Thanks.
All right, and finally, we have Dr. Shannon Murray, and she's here to present her research that she worked with under the guidance of Dr. David Guido regarding microRNA 144 mediating macrophage dysfunction in HIV-1 transgenic rats.
Hello, everybody. Again, I'm Shannon Murray, and I worked in Dr. Guido's lab. And to simplify that mouthful of words in my title, I'm going to be talking about impaired antioxidant defenses in HIV and the work we did in Dr. Guido's lab. So first, I have no disclosures. As we all know, HIV is incredibly prevalent in the Atlanta community, especially in the areas surrounding our main teaching hospitals, Emory and Grady. And because of this, we see many complications of HIV. And in particular, we see bacterial pneumonia is over 4 times more likely in patients who have HIV, even those who are treated with ARVs. And to begin to talk about this, we need to talk a little bit about the innate immunity of the lung, in particular, the alveolar macrophage. It is the job of the alveolar macrophage to recognize a threat and then activate components of the innate immunity to fight that threat and especially protect the alveoli against damage. And in our lab, previously in the work with Dr. Guido, they found that the alveolar macrophage may be implicated in reasons why HIV patients are more prone to get bacterial pneumonia. So the model that we use in our lab is an HIV transgenic rat model. It's a non-infectious rat, but it has HIV proteins, and 2 in particular are present in large numbers in the alveolar space, and that's TAT, which is important for gene expression, and GP120, which is an important docking glycoprotein that attaches to receptors. And this model is supposed to resemble seropositive individuals with on ARTs. And the main cell we were looking at was alveolar macrophages, and we obtained these through bronchial alveolar lavage. One key transcription factor that our lab has been studying is NRF2. And NRF2 is important for the alveolar macrophage function and its antioxidant defenses. Specifically, 2 of the antioxidant defenses it activates is NQO1 and GCLC. NQO1 is important for reducing free radicals, and GCLC is an important part of the glutathione synthesis pathway and neutralizing free radicals that could have damaged the cells. So in the lab previously, they had found that chronic expression of HIV-related proteins inhibits NRF2. And as you can see, the protein expression of NRF2 was significantly decreased in HIV transgenic rats, as well as GCLC, which is again another component of the antioxidant defenses. They also found that the phagocytic function of alveolar macrophages were significantly decreased when they were exposed to HIV proteins like GP120 and TAT. So the next question was, what is it that mediates this response of inhibition of NRF2 with HIV proteins? And to start to talk about this, we need to talk a little bit about basic gene expression. How a DNA gets transcribed to an mRNA, which is translated to a protein, and then modified to have specific function or activity. And one area where this can all be modified is through microRNAs. And what microRNAs do is they are small, non-coding mRNA, and they bind to a target mRNA and inhibit its translation into a protein, therefore silencing the gene. And one of the main microRNAs that we've been studying is miR-144. And this microRNA is increased in the alveolar epithelium of HIV transgenic rats. And it has been known to bind to the 3' untranslated region of NRF2 mRNA and inhibit NRF2 expression. So their question was, could this microRNA be implicated in why HIV inhibits NRF2? And what they found is that when alveolar macrophages were exposed to 2 HIV proteins, TAT and GP120, the level of miR-144 was significantly increased. And they also found that treating the alveolar macrophages with a miR-144 mimic significantly decreased the protein expression of NRF2 and GCLC. So my project, in conjunction with all these past projects, was looking specifically on how miR-144 mediates alveolar macrophage dysfunction. So this was the previous framework that was set up. We know that the HIV proteins somehow increase miR-144 expression, which inhibits the expression of NRF2, and then causes dysfunction in the phagocytosis and antioxidant defenses like NQO1 and GCLC. And our question to answer was, if we treat with a miR-144 inhibitor, would that restore levels of NRF2 and also restore the phagocytic function and antioxidant defenses in the alveolar macrophages? And our first question we had to answer was, does treating the HIV transgenic rats with a miR-144 inhibitor increase NRF2 expression? And the way we did this is we took the transgenic rats and then we treated them intratracheally with a miR-144 inhibitor, and we gave them 3 doses over 6 days. And then we obtained the alveolar macrophages through bronchoalveolar lavage, and we looked for the level of NRF2 that was expressed. And what we found was that treatment of the HIV transgenic rats with the miR-144 inhibitor significantly increased NRF2 expression, as well as its antioxidant effectors, NQO1 and GCLC. Our next question was, does treating the HIV transgenic rats with the miR-144 inhibitor improve the phagocytic function of the alveolar macrophages? And the way we did this is we took the same alveolar macrophages from the transgenic rats as well as wild-type rats, and we cultured them with a photored Staph aureus, and then we looked at these cells under immunofluorescence, and then we counted the percentage of cells that had bacterial internalization, representing phagocytosis. And what we found was that treatment of the HIV transgenic rats with the miR-144 inhibitor restored phagocytic function. And as you can see, these are some examples of my immunofluorescence pictures. And from the graph, you can see that the percentage of cells that had the bacterial internalization with the miR-144 inhibitor was increased very similarly to the levels of the wild-type rats. And the control inhibitor, the transgenic rats without the miR-144 inhibitor, was significantly decreased. So again, this was the basic setup in the prior work in the lab, and this is what we were able to find. That miR-144 is directly implicated in the reasons why NRF2 is dysfunctional in the alveolar macrophages. And some future directions would be to actually figure out what it is about the HIV proteins that are upregulating miR-144. And also, are there other areas that can activate NRF2? And the overall goal would be to translate this into a human model and see what implications that could have. I just want to thank everyone in the keto lab for taking someone who barely knew how to use a pipette into someone who understands basic science research. And that is it. Thank you for your attention.
All right, thank you, Shannon. So I would love to have all three of our oral abstract presenters come up for one more round of applause. And as they're coming up, I want to thank John Marshall for putting together an exceptional resident research day, and then also all of our faculty abstract reviewers, including Bhavin Adiaru, Mikhail Akbashev, Chris Knudsen, Sarah DeCaro, and Krista Johnson-Martinez. So one more round of applause for our oral abstract winners. Come on, I gotta see you. And then I don't think we have time for questions. If you guys want to meet us up front, if you have any additional questions for our residents, thank you.